Good morning, everyone. Thanks for coming this morning. I want to thank Sages for the privilege of the podium. I have nothing to disclose. So as you may know, international guidelines from the Enhanced Recovery After Surgery Society recommend the implementation of more than 20 perioperative interventions that are said to improve recovery after surgery. But it's easier said than done, as each intervention requires fine coordination and additional resources to be implemented. It's interesting from recent literature to see that regardless of the number and the type of interventions that are included in the pathways, ERPs have shown to improve outcomes consistently compared to usual care. When we evaluate the effectiveness of enhanced recovery programs, we shouldn't look only at outcomes, but we also should take into account the adherence to the pathway, so to the care process. And this is defined by literature as the successful completion of a planned intervention. That means if I'm planning to give solid foods to my patients on the first day after surgery, he actually has the meal on the first day after surgery. There are a few studies in the last years that have looked at the influence of adherence on outcomes and have found that a higher adherence does yield to better outcomes. But unfortunately, these studies were done in institutions where enhanced recovery programs were still being implemented and where overall adherence was rather low, especially in the postoperative period. And we still don't know if the statement holds true also in established pathways where overall adherence is higher. And it's still unclear what is the relative contribution of each element in the pathway to outcomes. So the objective of our study was to estimate in patients enrolled in an established enhanced recovery program to what extent the adherence with enhanced recovery interventions would impact on recovery after surgery, and furthermore to identify which were the key enhanced recovery elements that are associated with improved postoperative outcomes. We retrospectively reviewed a prospectively maintained database, the ERA Society Interactive Audit System, which allows entry for more than 140 variables, including care process and outcomes. And we included in our study patients who underwent elective bowel resection at the Montreal General Hospital between September 2012 and December 2014. So at McGill University Health Center, we first implemented an enhanced recovery program for bowel resection in 2006. It was further reviewed in 2010, and it is now applied to every elective bowel resection patient. It includes a large number of elements spanning from pre-admission educations to balanced intraoperative intravenous infusions to multimodal analgesia and early return to oral feeding and early mobilization out of bed. In our study, we chose as a primary outcome successful recovery, which is a composite endpoint that we defined as length of hospital stays of 4 days or lower, no postoperative morbidity, and no readmissions within 30 days after surgery. Furthermore, we also looked at length of hospital stay, 30-day postoperative complications, and also the Comprehensive Complication Index, which is a validated measure that takes into account not only the severity of complication, but also the number of complications, and assigns a value to each patient going from 0 being no morbidity to 100 being mortality. We performed a multivariate regression, adjusting for known prognostic factors, and we also performed a sensitivity analysis in which we excluded patients who had neurally postoperative complications because that could have influenced its adherence to the pathway. We included 347 patients. You can see that around a third of our patients had a low preoperative ASA physical status, and most of our patients were operated for malignancy. The most commonly performed procedure was segmental colectomy, but we also had around 35% of patients who underwent rectal surgery. Around 70% of our patients underwent a successful laparoscopic approach. Looking at our adherence to our enhanced recovery elements, we can see that adherence is rather high, especially when compared to previous literature, and it is consistent throughout the patient journey between preoperative, intraoperative, and postoperative course, and the median overall adherence is 78%. Looking closely at our different elements, we found that we had a low adherence for preoperative fluid management, but also for carbohydrate loading, while high adherence was found for a large number of items, including the multimodal analgesia and also the early return to oral liquids already on the day of surgery. Looking at our outcomes, we had 45% of patients who had a successful recovery according to our definition. The length of primary hospital stay was, the median was 4 days. 30-day postoperative complications occurred in 50% of our patients. It seems a rather high percentage, but this is certainly linked to our strict definitions that we employed. The 30-day comprehensive complication index median value was 8.6, which corresponds to a single grade 1 complication according to Clavian-Dindo classification. Looking at the relationship between the overall adherence to the pathway and successful recovery and complication, if you follow the graph, you can see in the blue line that as the number of the number of elements increases, the chance of having a successful recovery furtherly increases. And conversely, as the number of elements to which the patient is adherent increases, the 30-day complications decrease. If we look at this into numbers, we look that there is an actual dose-effect relationship between the adherence to the pathway and the successful recovery. So for each additional element to which the patient is adherent in the pathway, there is an odds ratio of 1.4 of having successful recovery. And this holds true also for length of hospital stay, where we have a reduction by 11% of length of hospital stay for every additional element to which the patient is compliant. And also 30-day complications significantly decreased, and the comprehensive complication index significantly decreases. When we look at our key components, predictors of successful recovery, you can see that in our multivariate model, laparoscopy was found to significantly predict successful recovery, but also early mobilization out of bed and early termination of intravenous infusion. When we look at our sensitivity analysis and we excluded those patients that had a complications in the first 48 hours after surgery, the results remain unchanged, and laparoscopy and early mobilization remain significant factors. The results for our secondary outcomes are very similar. We found that early mobilization, laparoscopy, and early termination of intravenous infusion remain significant predictors, but I also like to point out that epidural anesthesia prolonged length of primary hospital stay significantly, and this is actually in line with recent literature advocating that epidural analgesia for laparoscopic surgery within an enhanced recovery program does prolong recovery, actually does prolong length of primary hospital stay. Finally, I think it's important to point out that our study did have some limitations. Of course, it's a retrospective study, so it has a limitation of every observational study, but all the data was prospectively collected by an independent auditor. As outcome measures, we could only use audit measures, and we would have loved to use patient-reported outcome measures, but also physiological measures of recovery. So in conclusion, ladies and gentlemen, our study found that increased adherence to enhanced recovery interventions is associated with successful recovery outcomes, that within an established enhanced recovery program where overall compliance was high, laparoscopic approach, perioperative fluid management, and mobilization remain key elements associated with improved outcomes. So I think that our findings suggest that we should try to implement further measures to increase adherence to pathway interventions, and this is our latest proposal. This is an app to increase patient education and engagement in pathway, and I would love if you have time later, if you stop by and take a look at our presentations of an app for patient education self-audit within our enhanced recovery program, and we just pilot it. Thank you very much for your attention.